Kia ora koutou, no mai haere mai to tonight's webinar. My name is Katie McCulloch. I'm a nurse practitioner, and tonight's webinar is part of a series of webinars commissioned by Te Whatu Ora to support primary care. There are 3 sections to tonight's webinar. Tonight's webinar will cover skin prick testing for food allergy in children. Dr. Tammy O'Brien will discuss getting the basics right. And childhood eczema, CNS Carolyn Cordes will discuss the use of topical corticosteroids in the care of children with eczema, with some prescribing considerations, tips, and common concerns with their use. And we have our usual standing segment of clinical updates covered by Dr. Sue Tutty and Dr. Luke Luck. Tonight's speakers include Dr. Tammy O'Brien. Tammy O'Brien is a general paediatrician who works at Te Whatu Ora Waitemata. She has a special interest in childhood food allergy. CNS Carolyn Cordes. Carolyn works as a clinical nurse specialist in paediatric allergy and dermatology in Te Whatu Ora. She assesses children in clinics referred with eczema and food allergy. She's a nurse prescriber in primary health and specialty teams and an active member of the clinical reference group for Child and Youth Eczema Clinical Network, Te Roku Kirapai Hapori. She is passionate on provision of good education for whānau to manage their child's eczema and health. And we have Dr. Sue Tutty and Dr. Luke Luck, who are general practitioner liaisons. Over to you, Tammy.
Kia ora koutou, everyone. My name is Tammy O'Brien, and I'm a general paediatrician working at Waitakere Hospital. And I have the pleasure of talking to you tonight about skin prick testing in food allergy. So before I get to the skin prick testing, I just wanted to run through food allergy diagnosis. So food allergy is a clinical diagnosis, and it's based on a history of symptoms with exposure to a food, along with accompanying demonstration of specific IgE to the suspected food protein. And the gold standard is a supervised oral food challenge. Food allergic reactions are usually within minutes of ingestion of the food, and many occur on the first known exposure to the food. Foods eaten regularly and tolerated are unlikely to cause a food allergic reaction. There are several common allergens, including egg, cow's milk, peanut, tree nut, soy, fish, and wheat. And food allergy is common, with around 10% of under 5-year-olds having confirmed food allergy. Most children with food allergy also have eczema. So with skin prick testing, as mentioned before, when we have suspected food allergy, we need to confirm specific IgE present to that food. And this can be confirmed with either skin prick testing or testing blood for serum-specific IgE. Skin prick testing is preferred because it is cheaper, more sensitive, and it's less invasive. And it can be performed with either commercial allergens or with any fresh food. Lab Test in Auckland offers skin prick testing to the more common allergens, and I understand there'll be people from around the country who are watching this, and I am just acknowledging that access to skin prick testing is likely to be quite variable across the country. Serum-specific IgE may need to be requested instead of skin prick testing, depending on that availability within the regions. And also, skin prick testing may be difficult if children have quite extensive eczema with no good skin to use for testing. And for some children, the need for continuous antihistamine therapy will make skin prick testing not possible. So with all skin prick testing, there is both a positive control, which is histamine, and a negative control, which is saline. And this is to ensure that the skin with the positive control doesn't have any antihistamininergic effect. As if the positive control is negative, then the other results cannot be interpreted. Similarly, a negative control with saline is looking for dermatographism. And if this is positive, then other results cannot be interpreted. Skin prick testing can be performed from 6 months of age and older. It can be performed even if a child has had an anaphylaxis to the food in question. The testing should be delayed for some weeks to allow the mast cells to regranulate. Otherwise, you can get a false negative test result if it is done too soon after the reaction. Generally, skin prick testing is reported as a wheal measured in millimeters. A flare is often reported, but doesn't have any clinical utility. Any wheal that is 3 millimeters or greater is considered to be positive. A negative test of 0 millimeters virtually excludes allergy. But if the clinical history is very suggestive of food allergy, then it may be that an inpatient oral food challenge might be needed to clarify whether this is indeed a food allergic reaction or not, and discussion with a specialist would be advised. With skin prick testing, the bigger the size of the wheal, the more likely the chance of a reaction on exposure to that specific food. And there is good published data for both skin prick test and serum specific cutoff values, which are used to inform the probability of tolerance at a food challenge. And we're often looking at those values when we get the result of a skin prick test and the allergy history to decide what the next steps are. The size of the wheal, however, doesn't predict the severity of reaction. So you may have a 3 millimeter wheal, so a wheal that is just positive, and that child could have an anaphylaxis to that food, or you may have a 15 millimeter wheal and the child has a mild to moderate reaction. And just stressing again that the result of the skin prick test must be interpreted together with the history and not in isolation. So this brings us to the concept of sensitization to food. So we've talked about allergy being a clinical diagnosis where you marry the history with the positive skin prick test result. But just having specific IgE antibodies, so a positive skin prick test or an elevated serum specific IgE to a particular food does not mean that that person has an allergy to that food. A person who has specific IgE to a food, who regularly eats that food and tolerates that food, is sensitized to that food and should continue to eat that food. A patient who may have specific IgE that has been tested to a food that they have never consumed is also sensitized to that food, but not necessarily allergic, and they would require a food challenge to clarify whether they would tolerate that food or not. Children with atopy, so that's eczema, food allergy, asthma, or allergic rhinitis, have higher rates of food sensitization. If a child is tolerating a food that they are sensitized to, and the testing may have been done for a number of reasons, and then that food is removed from the diet because of the positive test, there is a real risk of losing tolerance to that food, and then later reintroduction of that food may result in a food allergic reaction. So just stressing that if the child is tolerating food and a test is positive and they're sensitized, they should continue to eat that food. So when is skin prick testing useful? It's useful to look for specific IgE in the skin to a food where there is a history that ingestion of that food on one or more occasions has resulted in a reaction which is characteristic of an immediate IgE-mediated reaction. And that might be a skin rash or hives, lip swelling, vomiting. There may be breathing problems, or pallor and lethargy to suggest anaphylaxis, or any combination of these symptoms. Skin prick testing is also useful to avoid unnecessary food exclusion. So maybe where a food is suspected of for having caused a food allergic reaction, but then testing is negative. And skin prick testing is also useful to inform the natural history of allergy. So doing a baseline skin prick test after a food allergic reaction, getting a positive result, and then down the line, if that child hasn't had any further accidental exposure or reactions to that food, repeating the skin prick test to see if the size has reduced or become negative to suggest resolved allergy or tolerance to that food. When skin prick testing is not helpful, so panels of skin prick test are generally not helpful because they can pick up sensitization and muddy the waters. So in general, the principle is to only test the food that on history is suspicious of having caused the immediate allergic reaction. So this might be teasing out in the history if a child has reacted to a meal and teasing out within that meal what foods were served to the child, which foods have been previously ingested and tolerated, and picking out what might be a new food in that meal. In general, do not do skin prick tests for food that's eaten regularly and tolerated in the diet, because you may find sensitization, so positive numbers, and then it muddies the waters in terms of people wanting to remove that food from the diet. In general, don't skin prick test for food that the child has never eaten, just in case they might be allergic, because if these tests are positive, then these children are sensitized to that food, and we don't know if they may be allergic. And it then creates the need to do oral food challenges supervised in hospital. And for most regions, there's a long wait list for those anyway. Skin prick testing is also not useful for non-IgE mediated reactions. So for skin prick testing in eczema, the general principle is not to do skin prick testing for eczema. So don't order skin prick tests or a panel of skin prick tests for bad eczema to see if the food is causing the eczema, because sensitization, as I've mentioned, will be more common in this group of patients, and the food does not cause the eczema. Do not order skin prick tests to help choose which formula to give a child with eczema. Again, food does not cause eczema, and finding either a positive or negative result is not going to help inform formula choices or milk choices. And do not order skin prick tests because parents are worried about food causing eczema. We should be telling patients and parents that food does not cause eczema. And again, finding sensitization can be difficult to explain to families. So when do we repeat skin prick testing? And so this is to inform the probability that a child has developed tolerance to the food and allow decisions about when to offer a food challenge. Generally, these will be guided by any recent accidental exposures. So in general, if a child has recently had the food that's in question and they've had a reaction, there's not really any need to repeat the testing, and you might review them in about a year or so. In general, we're also guided by the age of the child. So in children who are less than 5 years old, we tend to test more frequently, particularly for milk, dairy, egg, wheat, and soy. And as children get older, we space that testing out. So for the younger children, we would test 2 yearly once they're older than 5 years. And then for children, for the other common allergens, peanut, tree nut, fish, and shellfish, we tend to test less frequently, but still more frequently in that younger age group. So I was just going to go through some cases to illustrate the points that I've been talking about. So this is skin prick testing in real life. And some of these have come from recent triaging that have come across the desk. So these are real patients. So a 9-month-old presents after eating some muffin containing egg for the first time. This child has a small amount of muffin and then within 10 minutes developed lip swelling, a whole body rash, vomited once, but had no breathing problems. Apart from the rash, the child looks well and is alert. She has moderate eczema. And there's no other history of any food allergic reactions. And on a brief allergy history, she's drinking regular cow's milk formula. She's had some peanut butter on toast before with no reaction. So you organise some skin prick testing for egg, which comes back as 5 millimetres, with the negative control at 0 millimetres and positive control at 4 millimetres. So if we just have a think about what we're going to do here, we've got a 9-month-old child who's eaten baked egg for the first time and has had a mild to moderate allergic reaction. And skin prick testing has come back at 5 millimetres, so 3 millimetres and above is considered positive. So this is a positive skin prick test. So what this shows us is this confirms this child has an egg allergy. And we would advise avoidance of all egg as this child has reacted to baked egg. Part of the management of this child would also be to provide an ASCIA allergy action plan with antihistamine in case of accidental ingestion, and referral to paediatric clinic. And generally the plan that would be made for a child this age would be to avoid all egg and repeat skin prick testing to egg again in 1 year. Just before I go on to the next case, I just wanted to make a note about egg and milk, and you may have seen this in letters that have come to you where people talk about egg in baking or milk in baking versus whole egg and whole milk. So egg and milk are slightly different in terms of approach for allergy management. In general, if we have food allergic reactions, we'd be recommending avoidance of that food planning follow-up with repeat allergy testing. But the proteins in egg and milk are denatured with heating, which affects their tolerance. And so they require more active management rather than straightforward avoidance, because 80% of children who are allergic to the whole form of milk or egg can often tolerate the baked form, and getting that food into the diet has been shown in some studies to speed up the resolution of the food allergy. So skin prick testing results can inform that decision about whether the child should be offered baked egg or milk, depending on their clinical reaction and the size of skin prick testing. And it also helps inform whether that should happen in an inpatient supervised food challenge, or whether it can be offered safely at home. They also require active management with yearly testing in under 5s, because children will often outgrow their egg and milk allergy earlier than other allergies, with the majority outgrowing these allergies by school age. So here's another case. You have a 4-year-old who comes to see you for an allergy review. They had peanut butter for the first time at 11 months of age and developed a facial rash within minutes and cough and wheeze. They were treated effectively with eye and adrenaline by the ambulance, and the symptoms resolved. Since then, they've managed to completely avoid peanut and had no accidental exposures. The initial skin prick testing done at 1 year of age to confirm peanut allergy was 4 millimeters. And so you arranged to do follow-up skin prick testing, which had been planned from the paediatric clinic letter, and the skin prick test is 9 millimeters. So this is a child with a previous peanut anaphylaxis around 1 year of age, who's had a skin prick test that has increased and is now quite high at 9 millimeters. So you seek specialist advice from the paediatric clinic, and they note the skin prick test is still quite high. So normally you wouldn't consider a food challenge unless the skin prick test for peanut was 8 millimeters, and many would say 6 millimeters or less. So for this child, they should be advised to continue to avoid peanut, ensure they have a current EpiPen, ensure they have a current allergy action plan from ASCARE, with a plan to retest in 2 years. And I'll just note here that you may be asked if a skin prick test to peanut is favourable, so 6 millimeters or less, and we're considering doing a food challenge in hospital, you may be asked for the child to have a serum specific to peanut or a serum specific to the ARAH2 protein, in addition to the skin prick test to help inform decision, and that's something unique to peanut allergy. And around 20% of children will outgrow peanut allergy. And so just on to the last case. So an 8-month-old presented with vomiting and hives after drinking formula for the first time. She took 50 ml from a bottle and then developed symptoms after about 30 minutes. This child had previously been breastfed, but had had some formula in the first week of life as top-ups while breastfeeding was established. The mum is now returning to work, and so she wants to wean to a formula. Some solids have been introduced, including some baby cereals, pureed fruits and veggies, and these have all been tolerated. She has moderate eczema, which has been worse in the last 2 months, and the family have been using some moisturiser and some mild steroid. The family are concerned that the solids are making her eczema worse, and they are requesting allergy testing. So a panel of skin prick tests is arranged, and you see the positives that are there. So now we have to decide what to do with these results. So you would refer her to paediatric clinic, but in the meantime, because there may be a long wait for that, we have to advise the family what they should do based on the allergy result, on the allergy test results. So this child has had a mild to moderate reaction to whole dairy, and her skin prick test is positive at 10 millimeters. So you would be advising her to avoid all dairy because she has a confirmed allergy to cow's milk. She should also be advised to avoid all eggs. So in the history, she's never been exposed to egg, either in the whole form or in the baked form. And so she is sensitized, but has never been exposed. And we don't know what will happen when she eats egg. And so she will need to have an inpatient food challenge. She is also positive to peanut, and in the history she's never been exposed to peanut, so she is also sensitized, never exposed to peanut, and we don't know what will happen when she eats peanut, so she will need to have an inpatient food challenge for that as well. She can have soy milk formula, so she is over 6 months of age. Her soy testing is negative, and she has had a non-anaphylactic reaction, so this would be a suitable alternative for the mother who wants to wean from breastfeeding. And with the wheat, her wheat was positive, but you know from the history, you ask a bit more detail, that she has been having baby cereals containing wheat. She's tolerated this with no immediate food reactions, and so this should be continued in her diet. And also to explain to this family that it should continue to introduce new foods into this child's diet, even though she's had an allergic reaction. She also needs an ASCIA allergy plan and antihistamine available in case of accidental exposure. Once she gets to paediatric clinic, the likely plan will be made for her to have milk and baking. So as discussed previously, she's had a reasonable amount of whole dairy, and she's had a mild to moderate reaction. She has a positive skin prick test at 10 millimeters. But we know that many of these children who are allergic to the whole dairy will tolerate baked dairy. However, because of her testing being above the threshold at which we would consider introducing baked dairy at home, which would be 8 millimeters, this child would be recommended to have an inpatient food challenge to baked dairy to see if she can tolerate dairy in that form. So subsequent to being seen in clinic, she has food challenges to the whole egg, to which she was sensitized, never exposed, and she tolerates this, and also to peanut, which she tolerates. So in summary, food allergy is a clinical diagnosis, and the history is crucial to be able to interpret your positive skin prick test or serum-specific IgE results. Skin prick testing can demonstrate specific IgE to a food protein, and together with the clinical history can help confirm food allergy. Skin prick testing should not be done to look for allergy without clinical history. Positive skin prick test results to foods consumed without clinical history of allergy are consistent with sensitization, and these foods should not be removed from the diet, but continued in the diet. Only order skin prick testing to the suspected food causing allergy and avoid panels. And panels of skin prick tests should not be done for eczema. I'm happy to answer any questions.
Brilliant. Thank you so much, Tammy. That was extremely informative. We do have a few questions coming in. I'll just start with, at what age would you stop skin prick testing for food allergies and consider it to be permanent?
That very much depends. So we still actively would monitor most children up into the age that they go to adults. It depends a bit on the allergen. So with milk and egg, there still may be a chance, even once you've turned 15, at which point you would leave our service, that you might outgrow those allergies. And so we would be referring those children on to the adult services. However, if you were 15 and you had a persistent peanut or tree nut or fish allergy, you'd be unlikely to outgrow those, and so we probably wouldn't recommend follow-up of those children.
Thank you. If you have an infant who has an anaphylactic reaction to egg eaten for the first time and is breastfed, if the mum eats egg, is there any reason to withhold breastfeeding in the hours following the reaction? Is there any reason for mum to avoid egg?
Not usually, unless there's a history. So occasionally we do get children or babies who are breastfed where there seem to be foods that the mother consumes, she breastfeeds the baby, and almost immediately there's a red rash or increased itch. But in general, if children have confirmed food allergy and they're breastfed, we don't ask the mothers to avoid that particular food in their diet unless they're seeing reactions, but they're not. It's not common through breast milk, but possible.
Okay, even with dairy and things like that?
Yeah.
Interesting. Can you explain the advice that food does not cause eczema?
It's less advice and more hopefully evidence-based. So there have been a lot of studies looking at excluding potentially allergenic food from children who have bad eczema, and the results have not been good. And they're actually quite different mechanisms. And yeah, it's less sort of explaining it, it's more a dogma that I think we really need to explain to parents, because I think it's commonly perceived and often firmly held, the belief, and Carolyn will attest to this because I think she spends even more time than I do talking about this, that people perceive that food causes eczema because they want an explanation for why the skin is so bad.
Someone's just asking about immunizations and allergies, so egg protein and vaccinations. What's your thoughts on that?
So in general, you don't need to avoid any particular immunizations. I would have to look up, because some of the flu vaccines in the past had been grown on egg fibroblasts. But my understanding is that even if you have egg allergy, that you don't need to have your immunizations, including flu, performed anywhere special, even if you've had anaphylaxis.
Is RAST testing useful? Or what about
So RAS testing is the serum-specific IgE. So yes, it is an alternative to skin prick testing, but we do prefer skin prick testing. And RAS is sort of what it used to be called. So now it's now it's serum-specific IgE. So they're the same thing.
Okay. And GPs, NPs can arrange skin prick testing for under 5-year-olds. How do we go about this?
Yes, so in Auckland, so it will be different in different regions. I know there are some regions where GPs cannot request skin prick testing or serum specific testing, and it's all done through the hospital. In Auckland, you can request skin prick testing through lab test, and they do a specific number of allergens. There are more allergens offered on serum specific IgE, and you would just need to look up which ones were available.
Is there a preferred antihistamine that we should be using in under 2s?
We probably use cetirizine more than anything. Cetirizine or loratadine would be fine. Those are the two that we mostly use.
In terms of introducing allergens to children who with no history of, they're starting on their feeding journey, do you have any recommendations, or do you have any advice that we as primary healthcare practitioners can offer patients who are starting their children on food? Do they introduce allergens early, often? What's your thoughts on that?
So there's been a lot of study about this, because I think with the allergy epidemic, people have been trying to look for answers for how do we reduce the chance of food allergy, particularly in children who might have bad eczema and children with atopic family history. And so the recommendations at the moment would be that allergenic food is introduced early rather than avoided. So introducing foods between 4 and 6 months when your baby is ready, and including in those first foods, introducing the usual suspects. So egg, wheat, peanut, and not avoiding or delaying introducing those because you're afraid of allergy. And those are the main recommendations, is actually giving the food early and not avoiding it. And
do you need to keep up those? Do you introduce it to them once and then sort of leave it if they're not having any reaction, or do you continuously?
No, so that's a really good question, because what we think can happen is if you are introduced to food and then that food isn't continued in your diet, you may become sensitized to that food in the way we've spoken about. And then if you don't continue that food and then you're exposed to that food later, you may have lost tolerance. So it's important to introduce food into the diet and then to have that food regularly. So particularly things like peanut, which you might not eat too regularly as a family. It's important that that child has it 2 to 3 times a week in a child serving. So we'll sometimes see stories where babies might have had a little bit of peanut butter in that first year, but then it's not something that family regularly eat. And then they're 18 months old, they have peanut butter again, even if they've tolerated a few times in that first year, and they have a reaction because they've lost tolerance. So maintaining the food in the diet is very important.
Thank you. And can food allergies be inherited, and how likely is this?
So atopy can be inherited, and if you are atopic, you are more likely to have food allergy, but specific food allergies are not inherited. So if your mother has a peanut allergy, it doesn't mean you will have a peanut allergy, but your chances would be increased because you've probably inherited the atopic genes.
Someone's just asking if the size of the test wheel does not relate to the severity of the reaction. Is there a reason that we make plans based on the size of the reaction?
So although it doesn't predict the severity of your reaction, but it does give information about how likely you are to react to that food. So if you're thinking about doing a repeat skin prick test, so say we take the peanut allergic child in the case, that follow-up skin prick test was 9 millimeters, which is fairly positive. And so that says to us that we're pretty suspicious that that child would have a good chance of reacting to peanut if we gave that child peanut at food challenge. If that child had on repeat skin prick testing had a peanut wheel of around 5 millimeters, then that child would be brought forward for a food challenge because there would be a reasonable chance that that child might tolerate peanut. So it's partly to do with the size and also to do with the trend over time in terms of whether the wheel has reduced, increased, stayed the same.
Thank you. How long before a skin prick test must antihistamines be stopped?
3 days, so 72 hours.
Okay. And what do you do with those patients that do need the continuous antihistamine? You mentioned at the start that it's quite tricky to do skin prick testing on these patients and patients who have quite severe eczema. So how do you manage those cases where skin prick testing is indicated but is very tricky?
I guess it depends on how urgently you need to do the skin prick testing, because often what you're doing is you have a food allergic history where you're pretty suspicious about the food. And so what you might want to do is manage the eczema a bit more actively and see if you can get better control before you can do a skin prick test. Or sometimes it's just clear that these children have really difficult skin and we might actually go to a serum specific as a second choice. It's less common for us to see children who are on continuous antihistamine because many of our children are actually younger than 2 and so they don't have their allergic rhinitis yet. And so that's probably less of a problem for us.
Okay, awesome. So thank you so much, Tammy, and we'll move over to you, Carolyn.
So I'm going to talk about childhood eczema. I'm going to have a quick overview, but essentially have more of a conversation tonight about topical steroids. So as I said, quickly looking at some eczema management, looking at topical steroids, and particularly looking at topical steroids in terms of statements that I get from the families, and maybe why that leads to poor use of the steroids. Eczema is a chronic inflammatory skin disease. Its main characteristics are the itch, the pruritus that you get from that. It's a dry problem, eczematous lesions that are dry, inflamed, scaling, some crusted areas sometimes. And when it's chronic, you can have these thickening, the lichenification, and often pigmentary changes. And it flares up and it calms down. So it has this relapsing and varying times during its life. But why does eczema matter? Well, it's common in children. It can be easily up to 20% of children that can have some eczema. Most children will, or at least 50% will get their eczema by early months, 6 months of age. Most children start it by 5 years of age. And in general, a lot of the eczema clears by that early adolescence time. Adults can have eczema, and we're often noticing now the progression of more eczema into the later years and into adulthood than was previously thought. And eczema has become more common over the last numerous years. And it's actually very common to have consultations in primary care for eczema. But in eczema in the community, a lot of it's mild and only a smaller amount would be at the severe end. And it definitely has a genetic component. When you've got both parents having eczema, then the child is way more likely to have some eczema. And as we've discussed before, it's associated with other atopic diseases like asthma and allergic rhinitis. So really, when we're looking at eczema, we're looking at that upper layer of skin, the outside layer, the stratum corneum of the epidermis. And when you've got normal skin, you've got a good stratum corneum layer that looks a bit like a brick wall. It stops irritants getting in. When you've got eczema, you've got poor the poor outside skin layer that lets moisture out, and it can let those irritants in and get inflamed. And really our overall management is aimed at trying to repair that outside layer, putting a layer of moisturizer on to stop the penetration of irritants and to stop the progression of moisture out of the skin. But in terms of what we need to do for eczema, I think it's like putting several pieces of a jigsaw puzzle together, and one piece is not enough to care for eczema. You need to look at the whole picture of eczema management in terms of moisturizing, in terms of looking at what irritants and things could aggravate the eczema, in terms of potentially bacteria impacting on the eczema, and most definitely looking at the topical steroids. So quickly, when we're looking at moisturizing and bathing, I think there's less emphasis given to how a good moisturizer is applied, and you really want to consider smoothing it on downwards in the direction that hairs grow, not rubbing it up and down, but leaving a good layer to soak in. The product choice is probably the one that the child wants to use. The prescribed ones or the funded ones are perfectly reasonable, from the ointment based through to the more cream based ones, and generally numerous applications over the course of the day. If a child had completely clear skin, I would still recommend 2 applications a day, and an infant you might say at every nappy change. How much to use? Well, an older child to an adult could easily require 500 grams per week, maybe a baby 500 grams every 3 to 4 weeks. Bathing is certainly important in eczema management. Daily is our advice. Warm water for 10 or 15 minutes, no more than that. The active use of a soap substitute, using some on the hands and gently washing it over the skin. No evidence for adding something to the bath in terms of an emollient. Getting out of the bath, patting to nearly dry, and certainly they can be a little bit moist, and then putting the creams on quickly afterwards. Steroid first is our general advice, followed by the moisturizer. And just having a consideration about what potential irritants and triggers there might be for eczema, with soap being particularly important to be avoided. Fragrance products can sometimes be irritating. Heat and sweat. Synthetic or woolen fabrics are not helpful, so cotton-based fabrics next to the skin, much more important. Over time, dust and pollens can be aggravating and can penetrate through the skin and cause flares. Certainly in the older child to adolescent, stress can potentially be an irritant. And food is much less aggravating to eczema than is generally talked about. And things we can't avoid, the season, illness in the child that aggravates their eczema, and just literally growing and hormones. Some consideration around bacteria and skin infection, and eczema is predisposed to having bacteria sitting on it, particularly Staphylococcus aureus, and just having staph present on the skin can have that additional irritation and cause flaring, and much more susceptible to skin infection. And basic management is considering, having the skin in the best state it can be in, decreasing typical irritants, so think about soaps and the things we've talked about, having less flared skin, so reducing the inflammation, and also the addition of dilute bleach bathing to more frustrating skin, which we still find to be of good benefit in eczema management. So talking about steroids, so the typical effect we want from a topical steroid is that in anti-inflammatory aspect of it. Topical steroids go on the skin, they pass through into the dermis and bind to glucocorticoid receptor cells, receptors in a cell. So they stay in the skin and they calm that inflammation down, they calm the fire that's going on underneath the skin. And used wisely in pediatrics, steroids are safe. We rarely get the side effects that are often talked about, such as the sort of telangiectasia, the skin thinning, or stretch marks that are often talked about with steroids. It generally doesn't happen in pediatrics, but what we see very commonly is the underuse of topical steroids and therefore the failure of the management to calm the eczema down. And you often get this sort of steroid phobia where people are told to be worried about the steroid because it's very strong and therefore they underuse it because of that. So in New Zealand, we talk about 4 groupings of topical steroid. The mild group, which is your 1% hydrocortisone, mostly across the board in pediatrics and probably into adulthood, you would think about 1% hydrocortisone on the face. Moderate groupings such as Humavate or Aristocort might be for body areas of older infants, into the potent grouping of products like locoid, Advanton, mometasone or beta, often in the more frustrating skin in a school age child on the body. And typically super potent, such as the dermol, which can be up to 600 times as strong as 1% hydrocortisone, we would not be using in pediatrics. So I thought I'd talk about some statements that I still frequently get in clinic from parents. And they'll say things like, I don't know which cream to use where. And I think it's important when you're considering what you're offering the family to tell them where the particular steroid is meant to be used, whether it's the mild one and what specifically that is, where it's going to go, or the stronger one on using on body flaring. So consider writing on the prescription the specific area that the steroid is meant to go on, maybe write it on the box, and certainly producing, giving them written material like the eczema plan with the pictorial prompts for where to use the creams is really valuable for families. And I still frequently see the word use this sparingly, and sparingly really is a nonsensical word. It doesn't make sense. It means be scared of the steroid and use it inadequately. So what you want to do in terms of use of steroid and volume of it is consider fingertip units. And a fingertip unit is the squeezing from the tube from the first bend of an index finger to the end, which would cover about the size of 2 adult hands together. So that's one fingertip unit. And there's some good resources around, such as in the Auckland Regional Pathways of fingertip unit and where on a body, how much that would spread over a body part for certain age groups. For example, in a 3 to 6 month old, on the back of the trunk, including the buttocks, the whole of that area might need about 1.5 fingertip units. But bear in mind, that doesn't always make sense in reality, because you might get small areas of flaring and not need the whole fingertip unit. So really you want to have good coverage to the active or flared skin, and you might not need the whole fingertip unit for a body area. So a statement, I've been using the steroid for months and it doesn't work. And again, I have this frequently enough where they say they've been using the steroid frequently and they bring the tube in and there's hardly a dent out of the tube. It's hardly been used. So that's definitely leading to inadequate use of the steroid and therefore not calming the flaring down. And similarly, I have a small tube only of steroid. So for an older child, for example, a 15-gram tube may not be adequate for the amount of flared skin. And if we would consider a fingertip unit of steroid is about 0.5 of a gram. And in this scenario, a 6 to 10-year-old covering the whole body in fingertip units might need 24.5 fingertip units. That's 12.25 grams. So one tube may be used up very quickly in some children if you're using it on a larger surface area. So consider knowing the size of the tube that you're prescribing to manage the area of flared skin that you've got. I was told to use the steroid 3 times each day. Well, actually, there's no evidence for more frequent daily use, and generally no more benefit from once daily use. Within a few applications of a topical steroid, there's a reservoir that develops in the skin, and the saturation occurs. And really, you don't need to then add to that for more applications each day. 1 application a day is generally adequate and appropriate. And similarly with 0.5% hydrocortisone versus 1% hydrocortisone, this is the same molecule, and there may be a slower onset of help with the 0.5, but essentially it gets to the same molecule saturation after a while, and there's no extra benefit from 0.5. May as well just use 1% hydrocortisone. I was told to only use the steroid for 3 days. Possibly this is too short a length of time and it might not clear the eczema. And it's hard to say, well, you can only use it for a short length of time and then stop, because families will do that and they will use it for an inadequate length of time sometimes. The better information is to use until the lesions are no longer active but are feeling soft and flat and there's no itch. And in general, with good use, most eczema will clear or will be subsided within 14 days. If not, revise the plan and review again. I only use the steroid on the worst bits. Well, if you're ignoring milder areas of inflamed skin, you actually can't treat the whole skin well. It's important to use the steroid on all the inflamed areas. When you've got inflamed skin, it can send out messages and signals which actually keep sparking off the skin to keep flaring up. So the advice is really to use the steroid on all inflamed areas of skin. And similarly, I wait till the skin is real bad before I use the steroid. And if you're using that, sometimes you can not get on top of the eczema very well at all. So you really use the steroid at the first sign of flaring and continue into clear skin. And often starting the topical steroid earlier can mean quicker flare reduction and sometimes less applications overall. I don't use too much as I worry about the side effects. Well, that often leads to failure of the treatment plan and suboptimal use, and therefore the potential of more infections, skin infections, poor sleep quality for the child and maybe the family as well, poor concentration of the child at school, definitely the impact on the family, and embarrassed child not participating in life and schooling. And the typical side effect that most people worry about is skin thinning, which is actually very little evidence in pediatrics that occurs. And there has been some good studies to say longer length of time of even stronger potent steroids have not caused skin atrophy. So there's some good evidence for good use of steroids in pediatrics. So a 13-year-old saying, all I have is the 1% hydrocortisone and it doesn't work. Well, sometimes the ongoing use of a low potency is doomed to fail. You might need to step up in the steroid molecule in a stronger product. Sometimes you step up and then you can consider stepping down to a lower potency, and you need really a potency that's going to control the symptoms, the lowest appropriate potency. But sometimes a short burst of a stronger steroid can be much better than ongoing use of a milder steroid. The lotion doesn't work. And sometimes it's the vehicle that the topical steroid is in. And lotions are thinner, they're less helpful generally. And you might consider going to a cream or an ointment. Certainly in terms of strength, an ointment is stronger than a cream, with a lotion being the weaker end. And ointments you would consider for more drier skin or thicker areas of skin. creams for maybe larger areas of skin and lotions for skin that has hair on it. And often I just change from a cream version to an ointment version of the same molecule, and that can have quite good help. I use the Low-Quad on the face as it's the lower percentage than the 1% hydrocortisone. We'll just be careful because the percentage doesn't indicate its potency or its strength. And certainly with the example of 1% hydrocortisone, which is a mild, versus 0.1% hydrocortisone butyrate, which is your Low-Quad, and that's potent. Also careful with the some of the other molecules like clobetasone butyrate, which is the moderate, versus clobetasol propionate, which is very potent. So do be careful about your molecule prescribing, steroid prescribing. I was told not to put the steroid on broken skin. Well, eczema is essentially broken skin, and all scratched, excoriated areas really need treatment. They're scratched and excoriated because they're itchy and they're inflamed and they need calming down. And there's no good evidence that it can't be put on broken or excoriated skin. So use the steroid. And similarly, I'm not using the steroid as my child is on antibiotics. Well, most eczema is colonized by staph. And there's actually little evidence that steroid use on active infection will worsen the outcome. And in fact, it might aid in restoring that barrier function a little bit earlier. However, just be aware that ongoing use of steroid with no improvement in the skin, it could be that there's skin infection present and you might need some antibiotic. I mix a tiny bit of my steroid with a moisturizer. Well, in general, combining a topical steroid with another product like a moisturizer doesn't reduce its potency, but it might make it easier to apply over a larger surface area. But do consider how much is being mixed with a moisturizer, because too little may be ineffective. Generally, if you were mixing, you would consider 1-to-1 with a steroid to moisturizer if you're putting over a large surface area, and then stepping down to a tube and appropriate application with more improved skin. I think this cream makes it worse. But sometimes it's other ingredients within the topical steroid, such as lanolin, potentially within the DPHC, the 1% hydrocortisone lotion. Lanolin is a contact sensitizer, as neomycin can sometimes be within the pimifocort. And consider some of the scalp lotions, if they're being considered. Scalp lotions often have isopropyl alcohol as an ingredient, which will sting on broken skin. One product I use frequently is Low-Quad Corello, the milky emulsion lotion, which has no alcohol in it and therefore is much better tolerated in children for scalp flaring. I was told to use the steroid at the weekend. Is that right? Well, yes. Weekend maintenance has some good evidence around it. So it can be used for long-term, once or twice per week, often at the weekend days, to just calm the non-visible subclinical inflammation and be helpful at returning to more normal skin. So weekend maintenance has some good efficacy around it. And often we talk about a burst of a couple of weeks, a reducing or tapering plan, and then stepping down to weekend maintenance. I have used the ReadyPred and it works, but the skin flares up big time afterwards. Well, really, in terms of prednisolone is not indicated in eczema management. It can cause rebound flaring, has the potential for many more side effects, and it's much better to step up to a more potent steroid molecule than switching to a systemic oral steroid. Similarly, with a super potent topical steroid use in a younger skin, you can get rebound flaring. So again, I would not go to the more super potent molecules for eczema management in pediatrics. It doesn't look red, so I don't use a steroid. Well, just need to be thoughtful around eczema in skin of colour. With more pigmented skin, you don't see the erythema, the redness as much. You can get more colour variations and flaring that looks more brownish, purplish, hyperpigmented. And sometimes you get more of a follicular pattern eczema. And it has been said to be maybe more itchy skin in colour. And it's under-recognised, under-treated often when you have eczema in skin of colour. Some resources that I use, including Auckland Regional Health Pathways, but I presume your local pathways would be good resources to look at. The Child and Youth Eczema Clinical Network, and there's some other good resources around.
Brilliant. Thank you, Carolyn. I'll just ask you 2 questions if that's all right, because this has been coming up currently in the Q&A. Can you just briefly discuss the management of eczema around the eyelids and what steroids you would recommend?
So eyelids is challenging. I really understand it is, and you're worried about the thinner skin there. But I would still use some topical steroid, use it in slightly thinner in that area, but 1% hydrocortisone if you had inflamed skin in that area. But just simply using something like Vaseline petroleum jelly can be really helpful at moisturizing that area.
Okay, brilliant. And how long would you give a steroid to improve symptoms before changing to a more potent one?
Certainly you would hope to get some improvement in the skin within a couple of weeks, 3-4 weeks generally. If you're not, and there's certainly no improvement, then you need to revise the plan. You need to look at the bigger picture. Are they moisturizing enough? Is there other irritants going on? Is there something else at play that's aggravating things before considering changing to another product?
Okay, brilliant. Well, thank you so much, Carolyn. I really appreciate that. As we move on to our next segment with Dr. Sue Tutty and Dr. Luke Luck. Thanks, Carolyn.
Good evening, everyone. Sue and I are gonna give some update today about certain things. So thank you for coming. First thing we would like to give update is that as you already know, the combined pills has been changed from the Niflan to Orcon 30. As a funded medication from Pharmac. What we would like to let you know is that it is the same ingredients, but the active pills in Niflan is yellow and the inactive pills is white, which is completely opposite for the Orcon 30. So when one of your patients change their medication from Niflan to Orcon, when they finish their active pills, they go straight to the orange area in the Orcon, which means they go straight to the active pills, which is the opposite color of what they will take in Niflan. They continue doing that, and then they go into the inactive pills, which is the yellow color. It's also important to let your patient know that they may not have bleeding for the first month because you've been taking active pills continuously.
Thanks, Luke. The Continence Service has asked me to just discuss a little bit about the service that they provide. So this is a referral that you can do through the Community Health Service. So it's a e-referral, just on our usual process. And the patient will then be seen usually by the nurses or occasionally by a pelvic health physiotherapist. They see everybody from 4 years old and above, but counties will only see children if they have a condition that's affecting their normal growth and development. So they have slightly tighter regulations over who they see. And the service that they offer is a full assessment of the continence issue. So they'll look at bladder pattern analysis, they'll do a bowel assessment, bladder diary, and maybe a bladder ultrasound. So they're offering a fairly comprehensive service which involves bladder retraining, bowel management programs, education, recommending products and referral to other specialties like urology if that's required. They do an assessment and supply continence aids for people who fit the criteria for funding for that, but they're asking, please don't refer patients who then come to see them with the expectation that they will get their continence aids funded for them, because that may not happen, and it will depend on their assessment and whether they fit the criteria. The next thing I just wanted to remind everybody about was the first trimester combined screening. This is a particular problem at the moment in counties because of the shortage of midwives that we have. So I'm sure that you are all aware that it is quite a struggle to find a midwife for our patients in the counties area. Now, this is quite different in Waitemata, who I understand have enough midwives around at the moment. And in Waitemata then, and in Auckland, and even in counties, if you can enrol your patient, your woman, with a midwife as soon as possible, that's the ideal, because we do practice a midwife-based antenatal service. But if your patient cannot be seen by a midwife early in their pregnancy, then please continue to provide their care. This has helped because of the changes that did happen to Section 88, which is the funding that we get for maternity care in general practice. So now you can claim $75 per consultation that you have on any one day for a woman in the first trimester. So that's up until 13 weeks and 6 days. So if your woman is unable to see a midwife early in her pregnancy, please do see her back. Please go through the results of her antenatal bloods and just make sure that she gets them done. We have a number of cases all the time coming through who have had no antenatal bloods in their pregnancy. And it's such a shame when they have engaged with primary care early on. So first trimester combined screening, we're pretty good at ordering the scans because our women all come in and request the scan. But if you are going to do a 12-week scan, then please remember to give the woman the MSS1 blood test form as well that goes along with the scan, because it's those two together that allow the prediction of if there's any concern for abnormality in that pregnancy. So what we're screening for is trisomy 21, trisomy 13, trisomy 18, and some other rare conditions. If you miss that fairly narrow window for the ultrasound scan, which is from 11.2 weeks to 13.6 weeks, so there's only really a couple of weeks that you can get that 12-week scan in, then don't forget about the MSS2, which can be done anytime from 14 weeks to 18 weeks, or even up to 20 weeks if you need to. And I also just wanted to let you know about a change in the way we're doing the workup for women who have had a positive MSS1 or MSS2. This won't be a test that is ordered in general practice, but it's quite nice to be able to inform women who have had a suspicious test. And this is usually 1 in 300 risk, so it's still fairly low risk. And now we're offering the NIPT test, the non-invasive perinatal test, which is a blood test, rather than going straight to an amniocentesis or chorionic villus sampling, which is much more invasive. So it's only people that would have a positive NIPT that would need those more invasive tests. So just so that you know, that's a change in our guidelines.
Good. Thank you, Sue. Yes, just got a more specific request from Auckland Ophthalmology Service. At the moment, they are having a large number of referrals, so they just want to give a reminder for GP to ensure our patient to be seen in a timely manner. It's very important with in each referral we got a visual acuity uncorrected and corrected with glasses or pinhole. A tips that we want to give you is that if you want to do a pinhole, and if you don't have the special eye equipment, you just get a piece of paper, use a pen, pop that through, and that's gonna be your pinhole. And that will be helpful for them to triage the patient. Otherwise, like any history that we do, the onset, the duration, and the progression is very important, and to see is there any associated symptoms. The feedback they have is some of them is just quite brief, and they can't really decide how to triage the patient. And if any of our patients that we're quite worried that they can't see, they're having really bad headache, we worry there is acute glaucoma, it's very important that we call the ophthalmology registrar on the same day and ask for acute referral. And in my experience, I usually can see them very soon as well on the same day, you know. But if it's, you think that your patient will be seen within 2 weeks' time, definitely give them a call. The phone number of the ophthalmology registrar can be found on the Auckland Health Pathway. Finally, 2 more months, and I think we're going to be in Christmas. But happy Halloween for today. Just a kind reminder that the Auckland faculty from the GP College is organizing an end of year dinner and a Christmas quiz on the 7th of December 2023. So make sure you check your college email and register by the 12th of November.
Absolutely. Thank you guys for the clinical updates. We do actually have some questions that I'll just touch on, if that's okay, just regarding your clinical updates. They just want to, there's just a general question around the NIP testing. So does the GP order the NIP if the MSS is positive, and is it funded?
If it's positive, then you would do a referral to fetal medicine and they will order the test. So it's just so that you know about it and can advise the women. We wouldn't expect you to be ordering it. And yes, it is funded.
Brilliant. There's just a timely reminder to always test for syphilis antenatally. And there's just a question about the cost of scans for the patient. So pregnancy scans cost is a bit of a barrier, unfortunately.
We do know that it's quite a barrier for some of our women, and in counties we have a voucher system. Mm-hmm. You can go on Health Pathways and download a voucher that you can give to your woman if she has a community service card or is under 18.
And I just have one last question, and it's actually for Tammy and Carolyn, if that's okay. I'll just pop back to it. It's the last one that has been answered. Is there any relation between early signs of eczema and gastroesophageal reflux in babies and infants?
I'm unsure of any good evidence for that. I was looking at that and I'm really not sure.
Okay.
Same answer.
Brilliant. Okay, lovely. Well, I think that ties in. We come to the end of our webinar, and that ties in very nicely. There is a final comment on the Q&A that just says, "Thank you for the webinars. They've been very informative. Thank you, and take care." And I have to reiterate that I've really enjoyed tonight's webinar, and I hope everyone watching has as well. I can't thank you enough for joining us tonight, Tammy, Carolyn, Sue, and Luke. And thank you for everyone watching and joining us tonight from their homes. Have a lovely night, everyone. Ka kite.